8 questions you need to ask before you do IVF. Hi friends, I'm Dr. Natalie Crawford. I'm a board certified OBGYN and REI, so I'm a fertility doctor. And every day I sit here and I talk about your fertility, your health, and your hormones because I want you to understand your body better. And if you're going through IVF or your doctor's talking about it, I want you to be prepared for your cycle because too often I see people come see me for a second opinion who've been through a cycle and they just went with face value with what their doctor said. They didn't know what questions to ask. And they really had no sense of how they were doing throughout the process. And I don't want that to be your story. So we're going to quickly go through 8 questions I want you to ask before you do IVF. And this is going to help you take charge of what feels like an uncontrollable situation. Quick note, thank you so much for being here. Don't forget to subscribe, like, and share so that more people can find the channel. And you can pre-order the Fertility Formula, which is my debut book talking about your fertility. And if you do, pre-order bonus is the course, my IVF guide, which is going to walk you through details of some of the things we're going to talk about here, but much more information. So you can pre-order that at nataliecrawfordmd.com/book. All right, let's dive in. Number 1, what is my diagnosis and why is IVF recommended for me? This is important because different conditions are going to have different aspects you may need to think about for treatment. For example, if you have blocked fallopian tubes or you have male factor, then I'm not as worried about things like if you have endometriosis, how inflammation may be playing a role. There are actually different protocols. A patient with PCOS and a patient with low ovarian reserve should get different medications. And so you should know, why am I doing this? It might be unexplained infertility, but why is it recommended for me? How is this going to help me? And that's just going to help you frame correctly and put the right expectations in mind. Secondly, number 2 is, what's my expected success rate per cycle? And that's a difficult question we have to break down because it really will depend. And your doctor will probably say, it depends, because how old you are, how many eggs you're going to get, that's going to go into how successful you're going to be. I would more say, how many embryos do we think I'll get from one cycle? Because that's a measurement that we can understand a little bit better, because every embryo doesn't always equal success. With a single genetically normal embryo, we would have about a 65% chance of success per transfer, which cumulatively is really great, but on a single transfer basis means some people don't get pregnant even if everything goes right. So I want you to think through this and say, hey, number 1, how many embryos might we get? How many genetically normal embryos might we get? That's going to help refrain for you. Well, what are my real odds of success? How many transfers might I get? How many kids do I want? And let you think about big picture. And that's question number 3. How many eggs/embryos do I need for my goal? And I really want you to think about not just what's in front of you, because I understand if you're going through infertility, how terrible this is. I've been there and how you question everything. But I want you to think about, if things from here on out go perfectly, how many kids do you want in your family? I want you to think about that because this is the moment where decisions you make now could drastically change your family plan for later. So if you only want 1 child versus if you want 3 children, you're going to want a different genetically normal embryo goal. Not every egg is going to become a baby. There's normal attrition. So of the mature eggs, typically you see fertilization of about 75 to 80%. About 50% of those will make it to an embryo stage called a blastocyst, a day 5 or 6 embryo. And then genetic normalcy after there will depend on your current age at the time that you got the eggs out of your body. And then again, a single genetically normal embryo has a 65% chance of success. Well, 2 cumulative transfers gets you to a success rate of around 83%, and 3 gets you to about 95%, which means you want to have at least 2 to 3 genetically normal embryos to have an 80 to 90% chance of success of having a child. So I want 2 to 3 genetically normal embryos for every child I want in the future stored in the bank right now. Number 4, and this is a big one, what protocol are we going to use? Now, here's the deal. There's a lot of different medications that can work to do the job for IVF. The way I want you to think about this is medications to suppress your body and medications to stimulate your body. Suppression stops the brain from sending out FSH and LH. These are normal hormones that the brain makes that we don't want them to send to the ovaries because we want to control the ovary. Remember that the brain and ovary communicate together to get you to ovulate just 1 egg. We want to override this process. So if you have 20 eggs available, I want 20 eggs. Your body doesn't want to have 20 babies at one time. So, this is why we've got to use a suppression in addition to the actual stim meds. The suppression meds can vary. Their goal is to stop the brain from sending out FSH. You can use estrogen, progesterone, testosterone, ovulation blockers, a brain blocker called Lupron, birth control pill, and combination of the above. There's not necessarily one right protocol for everybody. And in fact, if your clinic says, this is the protocol we do for everybody, that's concerning to me. High responders should be on a different type of protocol. Typically, they're on what's called an antagonist protocol, which is an ovulation blocker. People who have really low egg counts, sometimes they need something different. People have endometriosis might need something different. And I want you to know at least what protocol you're doing. Red flag if it's always the same, no matter the patient scenario, because then there's not much personalization. And if you failed a cycle, this is a repeat cycle, I want you to know that your doctor's looking at that and making changes and adjustments in order to get the best chance of success. What size were the follicles when they were triggered? What trigger did you use? What was your estrogen? Do you need a different protocol? Do you need different days? Do you need to go longer or shorter? Do you need different doses of medication? Those are important questions to ask if you're not getting the outcome you want. When it comes to the stimulation, pretty much we're doing the same thing, meaning giving a lot of FSH and sometimes some LH. LH is only available in a combination FSH and LH called Menopur. FSH is usually can be isolated alone, like follistim or gonal F. And then sometimes you might see letrozole or Clomid in a cycle. You might see human growth hormone. Those are add-ons. You should know what you're doing. Is that the max dose? Is that a low dose? What is the goal here? Remember that an IVF lab can only work with the eggs and sperm you give them. So please, please, please pay attention to your life and work to decrease your inflammation, because inflammation is really toxic to egg and sperm quality. And that makes a big difference when we're going through something that's as emotionally, physically, financially, and time sucking as IVF. Number 5 is going to be, should I do genetic testing of my embryos? Genetic testing is when you take a small sample of cells from the placental segment of the embryo and you send that off, typically to find out about aneuploidy or an abnormal chromosome number. Remember that your eggs are in your body your whole life. The longer they sit there, the higher likelihood you're going to develop genetic abnormalities over time. And that means that the older you are, you're going to have an increased prevalence of genetic abnormalities. However, there's some other causes of infertility or for family planning reasons why genetic testing might be helpful even if you are younger. And I'm always in the camp of you don't know what you don't know. And if you're trying to make decisions now for your future, data is power. Number 6 is going to be, what are the costs and what's included? We do a package price at Fora, meaning this is the cost for the cycle. It's getting you from the start through to the end of the embryo genetics. And it doesn't matter how many times you come in or how much I see you or how much blood I draw, you're not going to be charged different. But some clinics do a la carte monitoring. So every time you have to go in, you have to pay more. If you go in on the weekend, there might be a weekend differential. You might be in a position where you owe more money for anesthesia, for the type of fertilization, for the storage of the embryos, for the genetics, for the freezing. So sticker shock is real. It's expensive. What we do in the lab is incredible, but it costs money. Number 1 is transparency is key. Number 7 is going to be, what are the risks and potential complications? Your doctor should say IVF is generally safe, but there are a few risks. Less than 1% of the time, you could develop, something that could be a complication from egg retrieval, like bleeding or infection, ovarian hyperstimulation syndrome. I always say the biggest risks are actually having the cycle canceled, which is your doctor doing the best thing for you, or saying, I didn't end up with any eggs or embryos, because sometimes we learn about you during IVF as well. And then number 8 is going to be, who am I going to see during the process and who am I going to talk to? If you're going through IVF, you go into the clinic for monitoring. This is ultrasound and blood work every 2 to 3 days. Are you going to see your doctor? Is there an ultrasonographer? Is there a nurse who's doing this? Does your clinic draw blood, or do you have to go somewhere else? How do you get results? Are they calling you on the phone? Is it a portal? Is it an email? It's hard to know when you don't know. We do doctor monitoring, which I know a lot of clinics don't, but I love seeing you during monitoring. I love giving you an update about what's happening. And I think it answers more questions. I think it's a better way to practice. But I know a lot of large clinics can't do that. And I'm not saying there's one right, one wrong way. This is how we designed our clinic. However, you should know what that way is for you. So you don't know what you don't ask. So ask who you're going to see and who is going to be giving you the results and how are you going to find them out. Know that IVF is not perfect. There's sometimes where cycles get canceled or things go wrong and you need a backup plan. But having expectations, knowing if things went perfectly average, what should I expect is going to help you. So before starting IVF, think about these things to ask so that you can be prepared for what this journey lies ahead. And as always, I appreciate you guys so much. Check out my book, The Fertility Formula, and you can listen to more on the As a Woman podcast right here on this channel. Thank you, friends.